Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Beijing.
This program is presented by Medscape Education Global.
Hello, my name is Sam Klempner. I'm a GI medical oncologist and associate professor at Mass General Hospital here in Boston, Massachusetts. And welcome to this program entitled Decoding PD-L1 Scoring, Guiding Immunotherapy in Gastroesophageal Cancers. Joining me today are our two colleagues and friends, Dr. Matteo Fassan, who's a professor of pathology at the University of Padua and head of the Department of Pathology in the Ca' Fongcello Hospital in Treviso in Italy, and Dr. Mar Iglesias, associate professor at the Universitat Pompeu Fabra and head of the pathology department at the Hospital del Mar in Barcelona, Spain. And thanks to you both for making time out of your day for this discussion. Really briefly, we're going to talk about PD-L1 scoring, the clinical rationale as to why we need this from all of our trials, the different scoring algorithms, particularly CPS and TAP scoring, the pros and cons of both, and talk a little bit about the concordance and agreement between these two scoring systems as we think about implementing them in the clinic. So I'm going to lead off just setting the stage about PD-L1 in gastroesophageal cancers. Of course, this is one of multiple biomarkers, but an incredibly important biomarker in optimally selecting patients for immunotherapy. We now have immunotherapies approved sort of across the spectrum of gastroesophageal cancers. In non-metastatic disease, we have nivolumab approved as an adjuvant after neoadjuvant chemoradiation containing therapy and surgery for patients that have residual disease. That was supported by the Checkmate 577 trial. We also just recently saw a positive press release from the Matterhorn study looking at FLOT plus durvalumab, so we're all very eager to see that data, which may change practice. And in the metastatic setting, we have a large body of evidence from multiple phase 3 trials examining the question of adding immune checkpoint inhibitors on top of 5-FU platinum chemotherapy, primarily in the frontline setting. And across the board, this has improved outcomes, including progression-free and overall survival. But now that we have all this data with different scoring systems and different antibodies, it's becoming increasingly important to understand both the scoring systems, how they're developed, some of the nuances between them, and the data that supports using both. So I'm now going to begin by turning it over to Mar and Matteo, where we talk about testing. I'm going to start by just asking Mar a sort of a general question about when we reach out to pathologists. So at least at our institution, PD-L1 is tested rather reflexively for the majority of gastroesophageal cases, both squamous and adeno. But maybe give us a little bit of perspective from your institution. How is the logistics of PD-L1 testing handled? Is it a request from the oncologist? Is it automatically done? Just give us your thoughts.
Nice to meet you. Thank you for the invitation. First of all, in our hospital, we work the same. We perform all the biomarkers that we need to be tested for gastric or esophageal cancer right now, as in a reflex mode and also in parallel. That's the reality in my hospital, but it's not the reality in all the hospitals here in Spain. Some of them, they need to be asked by the oncologist to test it just in the metastatic setting.
And then maybe I'll stick with you, Mar, for this one just a little bit more specifically. So how is PD-L1 testing done in your institution? Is there one antibody for every gastroesophageal patient? Is it you have capability of doing multiple and it's dependent on the drug the oncologist is looking to prescribe? How's it done?
There are two questions in this one. My institution is a reference site hospital, so we need to know the treatment, the specific immunotherapy the oncologist is going to give to the patient, and in that case, we will perform the specific antibody was related on the clinical trials. So if I don't have this information, I would do the 28A, 22C3, and next the SP263. But in my hospital, I need to mention that in the other hospitals, they will probably use only one of the antibodies because, as you may know, there are really good concordance between the three antibodies to test the PD-L1. But in my center, and it's not in all the hospitals, we do the 2+3 antibodies if we don't have the clinical information.
Yeah, so you have all the tools, which is wonderful.
Yes.
Um, and Matteo, I'm going to turn to you, sort of talking about just some basics of the input. Like, do you have a preference on the type of biopsy that you test? If, let's say, you have multiple biopsies available for a patient, would you test all of them if you had a liver and the primary tumor? Would you prefer to test one? How much material are you generally looking to feel confident in the result?
Oh, thank you very much, Sam, for the question. The main problem here is the type of sampling and the type of material that we have to be characterized for molecular testing gastric cancer. I will say in the Italian situation, the 70% of the patient, in the 70% of the patient, we have just the initial endoscopy biopsies to be tested. And in this setting, I would suggest a magic number, which is 6. If we have 6 biopsies representative of the adenocarcinoma, we have an adequate number of samples to be used for the characterization of all the biomarkers, HER2, PD-L1, MMR, and today also Claudin 18.2. Of course, we know that for PD-L1, we need just 100 viable tumor cells to have an adequate evaluation. But some authors demonstrated that higher the number of biopsies, better is the diagnostic accuracy of our report. So today, I would suggest to have a large number of biopsies of the primary tumor in the presence of a metastatic sample. Of course, there are some data published a couple of years ago in clinical cancer research, which demonstrated that there is a heterogeneity among the different metastatic sites. And so we have to discuss among us, among the group of people dealing with the gastric cancer patient, what is the best sample to be tested. But usually all the clinical trials have been based on the analysis of the primary tumor. So primary tumor first, and then, of course, we can discuss about retesting.
Yeah, I agree. It's a very similar experience here. The vast majority of the time we're working off a primary tumor biopsy. And I think over the years here, the GI endoscopists have gotten used to me, asking them for more and more tissues, like, 6 to 8 endoscopic samples if possible. Exactly like you said, we try to do the same. I'll ask you, Matteo, partly because I'm curious, but is your institution, is there a prioritization of the biomarkers? Does it go like mismatch repair testing, then PD-L1, then HER2, then Claudin, or sequentially? If is there an order, or is it pathologist dependent?
This is a great question. In my institution, we are trying to do all the biomarkers at the same time, because doing a biomarker at a time is wasting material. So what we are doing in all the locally advanced and metastatic cases is the complete evaluation of all the biomarkers, which are today, as I told you before, HER2, PD-L1, MMR, by immunohistochemistry, and Claudin 18.2.
Yeah, I agree. Our approach is very, very similar. I want to move on a little bit to the more detailed discussion of the scoring system. So you mentioned, combined positive score needing 100 cells. And more recently, we've seen some increasing data from tislelizumab trials and others with this tumor area positivity score. So Mara, I'm going to come to you talking a little bit about this methodology with both the idea of what, providers and patients should know, but also sort of explaining these two methods, CPS and TAP. What's the similar, what's different?
I think it's very important also for oncologists know how difficult or how is in fact the work of the pathologists. So both of them, CPS and tumor area positivity, are mathematical formulas. The CPS, I think, is a much more complicated way to determine a biomarker that exists nowadays. And in the numerator, you need to include the positive tumoral cells and also the lymphocytes and macrophages that are positive. You make a positive neoplastic cells if you see membrane stains, they are partial or complete of any intensity. This is going to be a positive tumoral cells, and you should include it in the numerator. In CPS, the only inflammatory cells that you will need to count are lymphocytes and macrophages. And the way of staining can be membranous, cytoplasmic, or most of the time, at least in lymphocyte, is kind of punctate. All of these kind of expression and any kind of intensity, it makes this lymphocyte or macrophage positive, and you should include it in the numerator. But then in the denominator, you need to include all the viable cells that has the biopsy. As Matteo says, if you've got 6 pieces of fantastic representation of tumor, you need to count a lot of cells and include them on the denominator. And then you may multiply by 100. TAP, tumor area positivity, is also a mathematical formula, but you include percentage of areas. It's an estimation of the areas that occupy the positivity in neoplastic cells and also inflammatory cells, respect the whole amount of tumor area. You can see that in both of them, you need to look at all the neoplastic cells, but the differences is that in CPS, you need to count, and it takes a lot of time. You need to be very concentrated to count all the positive and negative cells. In TAP, you will need to estimate an area. So you will invest less time to calculate TAP. I think for me, this is one of the main advantage of TAP. Another important thing is that in TAP, you don't need to look for lymphocyte of macrophages. You will include neutrophils or plasma cells. So that will decrease the subjectivity of the determination, because in the PD-L1 staining, trying to figure out this is not a plasma cell, this is a lymphocyte, can be really difficult. And all the time you need to move to the hematoxylin to be sure which inflammatory cells. With TAP, you don't need to do that. There's another differences, and it will be, I think, a kind of nightmare for the pathologists, and are the macrophages. In CPS, you include the intraluminal macrophages also. But in TAP, there's a sentence on the paper that mentioned that you should include only the macrophages that completely fill the intraluminal space of the gland. And this could be a little bit also subjective depending on the pathologist.
Just for the listeners and maybe for me who's not a pathologist, like, what is the actual difference in time, to do a CPS the right way versus a TAP? And, how many cases are you reading in a busy day? Because this would add up pretty quick.
I mean, when you start with CPS, it takes you half an hour per case. That's it. You need to count. And mostly if you have a lot of representation of the tumor. I mean, it's crazy, and you need to be really concentrated. So in my case, I do it 6:30 in the morning, because if not, I'm not able. That's true.
Yeah.
Of course, now you've got the really negative, the really positive, but the borderline ones, depending on the cutoff, maybe I still stay 10, 15 minutes per case. Imagine with all the biopsies we need to make the diagnosis is a lot of time. It's true that in the paper, TAP goes to 30 minutes to 5 minutes, but of course we will need to get used to TAP, and we will invest, I mean, 1/6 less time than in CPS. So it's going to be really fast compared with CPS.
Yeah, that's awesome. So if you had to teach a trainee or you had to teach me, you think the learning curve is faster for TAP
Yes.
or CPS?
No, it's going to be for TAP for sure. I mean, nothing is more complicated than CPS, and we've been doing that for the last 2 years. No, the curve is going to be, the teaching curve is going to be much more faster, and in some months, pathologists will read and will determine PD-L1 with TAP easily, much more easily.
Yeah, that is awesome to hear. I think I don't think many medical oncologists appreciate the difference as nicely as you explained it. I'm going to turn to you, Matteo, to sort of kind of bring this home with a few examples and cases to sort of highlight some of the points that Mar just made as well. So the floor is yours.
So thank you, Sam, and thank you, Mar, for the very clear explanation. I want just to share with you three representative examples. Um, the first case is Epstein-Barr virus-associated gastric cancer, and it's a traditional Epstein-Barr virus-related gastric cancer with a lymphocytic-rich histology, which is very common in this subtype of tumors. You see on the right of this slide the Eber positivity of the cancer cells, so demonstrating the positivity for the virus in this case. And we know that most of these tumors should be characterized by an overexpression of PD-L1. Of course, not of them, because we have some rare cases which are not so rich in lymphocytic infiltration, but this is the case, as you can see in this other slide, with the PD-L1 testing performed with the clone 22C3 in this case, in which you see on the top the normal gastric mucosa with some positive cells, and on the bottom the tumor, which is constituted by both neoplastic cells and also stromal cells. As Mara teach us, we have to focus only on lymphocytes and on macrophages. But as you see on this other higher magnification of the tumor, most of the cells are positive. No, you can also see some positivity in the peritumoral fibroblast, which can be also PD-L1 positive, but at a very, very low level of expression. This is a very nice case because Mara, I completely agree with Mara. In difficult cases, it takes 30 minutes to have a CPS, an adequate CPS evaluation. This is not the case because, of course, everything is positive, as you can see. Here we can see that the CPS is 100 because most of the cells are positive. The TAP is 100%, 95, no, 100% doesn't matter because, of course, this is a very strongly positive case. And also in this case, we can also assess, we can also say that if we have to evaluate TPS, the tumor proportional score, or the tumor cells are positive. So TPS is also 100%. Moving to a second case, which is the most difficult case. It's not difficult because you see that we have a very important positivity for PD-L1. It's difficult because we have to count. And so it's time consuming. On the bottom, you see the normal gastric mucosa. On the upper part of these slide, you can see the tumor going into an higher magnification. You see that the tumor cells are negative but are surrounded by stromal positive immune cells. Most of them are lymphocytes and macrophages, so we have to count them in the CPS evaluation. Also, in this other picture, you see that there is also some positivity in the tumor cells. I want to stress the fact that PD-L1 expression is not related to the intensity, so all the intensity of the positivity have to be recorded for the scoring system. And I will say in this case that we can say a CPS of 30 and a TAP scoring of 20%. So it's a case which is positive for all the different cutoffs available today in the clinical setting. I want just to stress at this point about intergranular macrophages, as already Mark said before. For CPS, we have to retain the intragranular macrophages for the scoring. For TAP, not. But if the macrophages are completely filling the gland, we have to keep them in the scoring system. So be careful about this point in the evaluation in the clinical practice. The third case is an interesting one. It's a locally advanced gastric cancer, in which you can see already a big difference between a superficial part of the lesion and the inner part of the lesion. The superficial part of the lesion is ulcerated, and we have not to consider the ulcer in the evaluation of PD-L1, because in the ulcer we have thousands of macrophages which are PD-L1 positive, but are not related to the tumor, are related to the ulcer. So please not consider the ulcer in your evaluation. And if we are going through this case, you see in this field, in this picture, no tumor cell, no stromal cell are positive for PD-L1. Also in this other part of the tumor, and in the last part you can see some positive cells, but of course, counting just some lymphocytes and some macrophages which are positive, we can assume that in this case has to be considered CPS lower than 1 and TAP lower than 1%. So these were three cases that are representative of our clinical practice. Some are very easy because they're completely positive and completely negative, and the difficult case because we have to count the cells. It's time consuming, but of course we have to consume the time to give to you, Sam, to our oncologists, the way how to treat our patient. I want to stress maybe the last point is how to deliver the information in our histology report, not just positive and negative according to the different cutoffs, because cutoffs are changing, and you, of course, will show us the differences in the different clinical trials. Usually, we put the absolute value of our CPS and TAP scoring in the report.
Yeah, I think that's definitely much appreciated by us on the clinical side as well. I did not appreciate the ulcer nuance, and that it makes total sense. I just did not know that area needed to be excluded in the evaluation because of the inflammatory, infiltrative response. I'm going to bring us home and walk a little bit through the clinical data that sort of supports everything that you just heard and why it's so important. We have a very large body of data now, probably close to 10,000 patients treated with chemotherapy or chemotherapy plus immune checkpoint inhibitor combination. So it's nice that we're getting into some granular levels of data in terms of cutoffs and how patients do at various cutoffs. I'm not going to spend a lot of time on each of these slides because, one, this information is widely available. And two, you don't really need to listen to me reading for a long time. But I'm briefly going to walk through some of the practice-changing studies that led to the need to adopt this testing and make sure that it's done in an appropriate way. But sort of walk down the esophagus from including squamous esophageal down to esophageal adeno, GE junction, and gastric. So the first trial that we have, and the way these trials have been implemented around the globe varies slightly. So you've heard about heterogeneity in testing. There's also heterogeneity in the way that people interpret the data, and some guidelines in Europe, like ESMO, may differ slightly from the guidelines in the US, like NCCN, may differ slightly from the Japanese guidance and Korean guidance, for example. But Keynote 590 was a very large phase 3 trial asking the question about pembrolizumab on top of 5-FU platinum therapy, primarily in esophageal cancer. You can see that this is a trial that includes squames and adenos, and in the NCCN and ESMO, the guidelines are relatively harmonized around the squamous cut points. And in esophageal adenocarcinoma, which was a slightly smaller component of this trial, you can see that in the US, we have chemotherapy with pembrolizumab for CPS greater than or equal to 1, and a stronger endorsement for greater than or equal to 10, whereas ESMO has stuck with the 10 guideline. 859, another pembrolizumab trial. This essentially moved somewhat down the esophagus in mostly GE junction and stomach, asking a very similar question about the addition of pembrolizumab on top of 5-FU platinum therapy. Pre-specified endpoints are CPS PD-L1 greater than or equal to 1 or greater than or equal to 10. And you can see that in both guidelines here, there's endorsement for the PD-L1 positive, defined by greater than or equal to 1 in this case. So Checkmate 648, which is a squamous esophageal trial, had 3 arms, and there's quite a fair amount of data in here. And in the supplemental publication, there's also a nice lookup table looking at TPS, so tumor positivity, and CPS, the combined positivity. They didn't do TAP, but they looked specifically at tumor cell positivity. And you can see that both Nivo and IPI beat chemo, and Nivo plus chemo beat chemo. And you can see that this is broadly approved for squamous cell cancers of the esophagus, both in the NCCN and ESMO. And then Checkmate 649, which was really the first trial to bring this to the clinic, was more of a GE junction and gastric adenocarcinoma trial. There were some esophageal adenocarcinomas as well. And this initially was a very broad approval for all comers. And then the guidelines have subsequently endorsed this primarily at PD-L1 cutoffs. You can see 5 being one of the more evidence-supported cutoffs in 649. Finally, I'll talk about the newest data sets, which are the tislelizumab trials, Rationale 306 and Rationale 305. So these, again, ask a very similar question about adding checkpoint inhibitor, in this case, tislelizumab, on top of 5-FU platinum chemotherapy. So 306 was primarily a squamous esophageal trial, or entirely a squamous esophageal trial. And this was really where we started to introduce the idea of tumor area positivity into prospective trials as opposed to post hoc analyses. And here you can see that there was some pre-specified subgroups looking at TAP greater than or equal to 10 in the squamous esophageal. And you can see that in the FDA recent approval for this frontline, it's given to PD-L1 greater than or equal to 1. They do not actually specify the method that is required for tislelizumab. You can use any method that validated, so that would include TAP or CPS scoring. And you can see that the European medical authorities restricted this to a TAP of greater than or equal to 5%. If you move into the adenocarcinoma world, again, here we saw a TAP of greater than or equal to 5% as one of the pre-specified TAP subgroups. And again, the FDA and EMA slightly divergent. The FDA perhaps a little more liberal with approval for positive as defined greater than or equal to 1 by any scoring system, and the EMA sticking with the greater than or equal to 5%. In the final couple minutes, I just want to talk a little bit about concordance and then ask Mar and Matteo about concordance, because we've started to see this in some clinical trial data. And I know Matteo and I were both involved in this publication, which essentially was looking really at the concordance between CPS and TAP across the most common antibodies. So 28.8 was the antibody used in the trials with nivolumab. 22C3 has historically been the antibody used in the pembrolizumab trials, and SP263 is increasingly being used by multiple companies for tislelizumab, as well as a few other trials and the recently published Gemstone 303 trial as well. And I think what you can see is that the pre-specified cut points of greater than 1, greater than 5, and greater than or equal to 10, whether you use SP263 TAP on the left, and then across the top are CPS and TAP with the various antibodies, you can see that the concordance at the upper level is quite good. And I think that was kind of alluded to by Mar and Matteo as well, and highlighted in a couple of the examples. It's at the low end, the greater than or equal to 1%, where the concordance or the inter-observer agreement is a little bit lower. And that's true for most biomarker testing, I would suppose. But I think the take-home message for here is that there is substantial, if not almost perfect, agreement at the upper levels, suggesting that there is equipoise for CPS and TAP as a test to understand the expression of PD-L1. This slide really just highlights at the low level, you can see with each green bar being a case, there are some cases where it is classified as greater than 1 by one assay, and then not classified as greater than 1 by another. So primarily this is on the low side if you look at CPS 1 and TAP 1% groupings. But perhaps even more importantly, we've actually seen this generated from clinical samples. So this is the rationale 305 biomarker analysis. And you can see that the vast majority, we've got almost 1,000 patients here, had TAP scores and post hoc CPS scores. So from the same patients in a prospective manner, very high level of rigor and evidence here. And you can see that the prevalence of these groups is pretty well matched, which hints at the idea that a CPS greater than or equal to 1 is also going to be a TAP greater than 1%. And you can see the breakdown here. So, very high scores is also not an incredibly common phenomenon in gastric and esophageal cancers. You see here the percentage of patients with scores greater than or equal to 10% is around a third or less. So a lot of our patients live between the sort of 1 and 9, or maybe even 1 and 5 kind of range. And you can look at the percentage here and you can see that the bulk of patients fall within those groups. But I think the message is that the prevalence of the individual strata is similar across the TAP and CPS. I think enhancing the confidence in the ability to use TAP to identify patients. And this is just graphically showing the outcomes by TAP and CPS. And so if you take 1% or 1 as the cut point, and you do that by TAP or CPS, you see that you get very similar outcomes. This would be comparing the upper left versus the lower left, middle versus the panel below that, and the upper right versus the lower right. And you can see that the outcomes, whether you classified those patients by TAP or CPS, are extremely similar. Again, sort of enhancing our clinical confidence that we can use these systems, I wouldn't say entirely interchangeably, but a result can be felt as real. And this is really just showing again the prevalence. I'll leave this for the audience to review. And I want to sort of wrap this up by bringing it back to our pathologists who are really doing most of the work here and generating this data. So Mara, I'll start with you. Sort of final thoughts on the topic of PD-L1 scoring in gastroesophageal cancers, and maybe if you could speak specifically about flexibility, like you on the pathologist side, you have availability at your institution of all of these assays and all these scoring systems. So just sort of high level preferences, flexibility, confidence in score of one system and another.
I think that TAP is one of the determination we will need to do from now. We, first of all, need to be used to, we need to train, but at the end, seems like we will be able to use any of the assays in the different platforms with a small validation, of course. And then, at least at the beginning, I recommend to include both determinations, CPS and TAP. There are publications regarding the concordance about TAP and CPS, as you just mentioned, but I think we need a little bit more of scientific evidence. But at least at the beginning, give the two determination, and then we see if in fact is concordant, both of them, because TAPs with training seems to be easier and faster for us. So TAP is coming. We will need to be trained. And at the end, we see if it's going to be the only way to measure PD-L1, because seems it's going to be easy for us.
Yeah, I noticed in ongoing clinical trials, TAP is increasingly being used as the system, and sounds like people are listening to you and Matteo endorsing this as perhaps the preferred approach. Matteo, similar question to you. If you had to leave the audience with some key points about PD-L1 testing in gastroesophageal cancers.
Now, Sam, you explained to us how it's important today to have the PD-L1 evaluation as an initial step in the therapeutic management of our patients. So I think that in all the locally advanced metastatic gastric cancer and esophageal squamous cell carcinomas, we have to put the PD-L1 evaluation in our histology report. And as Mar explained to us, how is easy TAP in the evaluation in comparison to CPS. Today, we have to report both CPS and TAP in our histology report. This is the beginning of the therapeutic management of our patient, and so we have to underline and stress this point.
Well, look, thanks to you both. This was great. Thanks to everybody for tuning in and listening. And please continue to answer the questions that follow and complete an evaluation so that, we can do this better the next time. Thanks again.
This program was presented by Medscape Education Global.